This is Kumari Surabhi. Here in this video, I'm going to talk about the sensory testing and reflexes. Here I'm introducing myself, confirming patient details with my patient, and explaining examination procedure to my patient, gaining consent of my patient for the assessment of sensory testing and reflexes. For testing sensation, use a symmetric pattern on both sides of the body. Comparison helps to better identify where sensory losses occur by identifying of sensory abnormalities and the kinds of sensation affected. With patient health history in mind and after good hand hygiene ready for the physical examination, begin by assessing pain sensation in arms, legs, and trunk. First, warn patient, then use the sharp end of cotton swab stick. Ask the patient to close eyes, then starting with the arms, test scattered areas in a symmetric pattern on both sides of the body. Assess light touch with cotton wisp. Ask patient to tell whenever they sense the touch. To test position sense or proprioception, hold the sides of the patient's big toe with your thumb and index finger. Avoid touching the other toes. Ask the patient to close eyes and identify the direction of motion. Repeat several times on each side in an irregular sequence. Then compare with the big toe on other foot up. Again with the patient's eyes closed, test position sense in the upper extremities, beginning with the finger on each of the patient's hands and moving more approximately to the metacarpopharyngeal joints and beyond. Test discriminative sensations beginning with stereognosis, the ability to identify objects by feeling it. Ask the patient to close eyes, then place a familiar object in the palm and ask the patient to identify it. Repeat the procedure on the other hand using different object. To test graphesthesia or number identification, ask the patient to close eyes and use blunt object to draw a large number on the palm. 2-point discrimination. Using two ends of an open paper clip or ends of two pins, repeatedly touch the patient finger pad with the 2 points and with 1 point occasionally. Ask the patient to identify if pin being touched with 1 or 2 points. Minimize distance between 2 points so that can determine the minimum distance at which patient can identify 2 points. On the finger pad, distance should be less than 5 millimeters. To test point localization, ask the patient to keep eyes closed, then touch a point on the patient's skin. Ask to open eyes and point to the place touched. This test is especially helpful for locating sensory loss on the trunk and legs. Assessment of reflexes. When assessing deep tendon reflexes, grade them on a scale from 0 to 4 plus. 0 reflects no response, 4 plus is very brisk hyperactive response. By definition, it must be accompanied by rhythmic oscillation between flexion and extension. In assessing deep tendon reflexes by testing the biceps reflex, Patient arm must be relaxed, partially flexed at the elbow and positioned with the palm down. Depress the biceps tendon with your thumb or index finger. Strike your thumb or finger briskly with the reflex hammer. Feel the biceps muscles contract and see flexion of the forearm. Press the triceps reflex. Flex the patient's arm at the elbow with the palm toward the body and pull the arm slightly across the chest. Strike the triceps tendon above the elbow. Watch for contraction of the triceps muscle and extension at the elbow. To elicit the supinator or brachioradialis reflex, patient's forearm should rest on the abdomen or lap with the forearm partially pronated. When patient is ready, strike the radius 1 to 2 inches above the wrist. Observe for flexion and supination of the forearm. Knee reflex. To test knee reflex, locate the patellar tendon with the patient's knee flexed. Briskly tap the tendon just below the patella. Note contraction of the quadriceps and look for quick extension of the knee. A hand on the anterior thigh. Feel this reflex. Supporting both knees at once allows you to assess small differences between the reflex of each knee. Test the ankle reflex. If patient is sitting dorsiflex the foot of the ankle, ask the patient to relax and strike the Achilles tendon. Watch for the plantar flexion at the ankle and note the speed of relaxation. If patient is lying down, flex one leg at both hip and knee and rotate it externally so the lower leg rests across the opposite. Then dorsiflex the foot at the ankle and strike the Achilles tendon. Repeat this test on opposite side. If knee and ankle reflexes seem hyperactive, test for ankle clonus. Support the knee in a slightly flexed position with your other hand. Dorsiflex and plantar flex the foot at few times. And then sharply dorsiflex the foot and maintain it in dorsiflexion. Look and feel for sustained rhythmic oscillation between dorsiflexion and plantar flexion. To test for plantar response, use an object like an applicator to stroke lateral aspect of the sole of the foot from the heel to the ball, curving medially across the ball. If suspect meningeal inflammation, test for meningeal signs. First, make sure no injury to the cervical vertebra or cervical cord with the patient lying down. Place your hands behind the patient's head and flex the neck forward until the chin touches the chest if possible. For low back pain with nerve pain that radiates down the leg, test straight leg grazing for Ambo Sacral Radiculopathy. Raise the supine patient relaxed and straighten leg, flexing the leg at the hip, then dorsiflex the foot at an angle of about 60 degrees.